Welcome to the deep dive. Today we're tackling cholecystitis. It's a really common gallbladder issue, but one that can get quite serious. Think of this as your focused revision session on it.
That's right. Cholecystitis, basically inflammation of the gallbladder.
Yeah.
And knowing it well is pretty crucial. We'll break down everything, what it is, the complications,
Yeah,
try to make it stick.
exactly. So our mission here is a clear, high-yield overview for your revision. We're hitting all the key parts: definition, causes, who's at risk, how it actually happens inside.
What else it could be, how common it is, the
Yeah.
symptoms, investigations.
Yeah, how we find it, treatment, prognosis, and what can go wrong. We're pulling from good sources like the Oxford Handbook, Kumar and Clark's, BMJ Best Practice, Radiopedia, NICE's guidelines, that sort of thing.
Definitely.
So let's dive in. What exactly is cholecystitis? How do we define it?
Okay, so at its simplest, it's inflammation of the gallbladder.
Yeah.
And the most common reason, usually gallstone blocking the cystic duct, it's the little tube draining the gallbladder. This blockage can cause a sudden acute flare-up, or sometimes more of a long-term chronic irritation. And it's really key to remember, if you don't manage it, it can lead to some pretty serious problems.
Okay, so gallstones blocking the exit main culprit. Are there other ways this inflammation can start, though?
Yeah, good question. While gallstones in the cystic duct are definitely number one, other things can cause it. You could get a blockage in the bile duct from something else, maybe a tumor,
Oh, okay.
or, less commonly, an infection starting in the gallbladder. And sometimes, though it's quite rare, trauma or even certain parasites could be involved.
Interesting. So it's not always about stones getting stuck. Now, thinking about who gets this, who's more likely, what are those key risk factors?
Well, for remembering the risk factors for gallstones, which then increases the risk for cholecystitis, there's that classic mnemonic, the four Fs.
Ah, yes, the four Fs.
Yeah, though it's maybe not perfectly precise anymore.
Hmm.
Traditionally, it was fatty. So obesity, female, 40 meaning older age generally, and fertile.
Right, though fertile is more about pregnancy hormones, isn't it? And 40 is just a general idea for older age.
Exactly. So 40 is more like older age, and fertile points towards hormonal changes like in pregnancy. But still, the four Fs can be, useful hook to remember those associations.
It's a handy memory aid. What else puts someone at higher risk?
Okay, so beyond those sort of demographic things,
Mm-hmm.
if you've had gallstones before, you're obviously more likely to get them again.
Makes sense.
Also, things like rapid weight loss or even prolonged fasting can surprisingly increase the risk. A sedentary lifestyle doesn't help either.
Right.
And then there are certain medical conditions and meds, hormone replacement therapy, diabetes, cirrhosis, Crohn's disease. They're all linked to a higher risk as well.
Okay, so we know what it is, who's more at risk. Let's get into the mechanism. What's actually happening inside the gallbladder when cholecystitis kicks off?
Yeah.
The pathophysiology.
Right. So picture that gallstone lodging itself in the cystic duct, blocking the way out for bile. Straight away, bile starts to back up inside the gallbladder. This trapped bile irritates the gallbladder lining, causing inflammation.
Uh-huh.
Then the gallbladder starts to stretch and swell up. That's called distension. This makes pain and inflammation even worse. And because the bile is just sitting there, stagnant, it's easier for bacteria to grow, leading to infection.
So the blockage is the trigger, but then inflammation and infection make it much worse, like a blocked drain causing a nasty backup.
Exactly. The severity really depends on how much inflammation happens and whether infection sets in.
And if this just carries on untreated, what are the dangers?
Well, the inflammation can actually make the blockage worse, sort of a vicious cycle. If it goes on too long, the gallbladder wall can lose its blood supply and start to die. That's gangrene.
Wow, okay.
Or it could even burst a perforation. Both are really serious, potentially life-threatening. Even without those extremes, you could get abscesses forming, or peritonitis if bile leaks into the abdomen, or even sepsis, which is, a massive infection throughout the body.
That really drives home why sorting it out quickly is so important. Now, if someone comes in with that kind of belly pain, what else could be going on? What are the main differential diagnoses?
Yeah, crucial question. Several things can feel quite similar, especially that pain in the upper right abdomen, the RUQ.
Right.
You've got to consider biliary colic, that's also gallstone pain, but usually comes in waves and doesn't have that significant inflammation of cholecystitis.
Okay.
Then there's acute pancreatitis, inflammation of the pancreas. That causes severe upper abdominal pain too, often going through to the back, and you'd usually see high amylase or lipase levels in the blood.
Got it.
Peptic ulcer disease or GERD reflux, they can cause upper abdominal discomfort, but the pain's character and other symptoms are usually different.
Mm-hmm.
And even appendicitis, although it typically starts lower down, can sometimes present atypically higher up. So yeah, you need a good history, exam, and tests to tell them apart.
Sounds like a few key mimics to keep in mind. Stepping back a bit, how common is cholecystitis? What's the epidemiology like, say, in the UK?
Well, it's estimated maybe 10 to 15% of UK adults get gallstones at some point.
So quite a few people.
Yeah. And while not all of them will get cholecystitis, a fair number do. Like we said, with the risk factors, it's definitely more common in women. And the chances go up as people get older. So yeah, it's something you see pretty regularly in clinical practice.
Okay, fairly common then. So let's get specific about how it presents. What would someone with cholecystitis typically experience? What are the clinical features?
Okay, the classic acute presentation, it's usually severe, constant pain in that right upper quadrant, the RUQ.
Right, top right of the abdomen.
Exactly. And that pain often travels, radiates to the back or sometimes even up to the right shoulder blade. Patients often have a fever, feel sick and nausea, and might vomit.
Uh-huh.
And when you examine them, they'll be very tender if you press over that gallbladder area. Sometimes, maybe in about 10% of cases, they might get jaundice, the yellow skin, and eyes if a stone is also blocking the main bile duct.
And what about chronic cholecystitis? Is that different?
Yeah, chronic tends to be a bit milder. The symptoms often come and go, intermittent pain or discomfort, maybe some indigestion. Particularly after fatty meals, it's more of a grumbling picture.
So that RUQ pain may be radiating to the shoulder, fever, nausea, those are key for acute. Are there any specific signs on examination we should look for?
Absolutely. A really important one is Murphy's sign.
Yes. How do you do that again?
So you place your hand or fingers gently under the right rib cage in the RUQ and ask the patient to take a deep breath in. If they suddenly stop breathing in because it causes sharp pain as the inflamed gallbladder hits your fingers, that's a positive Murphy's sign.
Pain that literally stops them breathing in.
Pretty much.
Yeah.
And importantly, it shouldn't hurt like that when you press on the left side.
Yeah.
Also, sometimes, especially if a stone is really stuck in the cystic duct, you might actually feel a lump, a palpable gallbladder mass in that RUQ. Oh, and don't forget Charcot's triad. That suggests something more severe, like an infected common bile duct obstruction. RUQ pain, jaundice, and high swinging fevers with chills and rigors. That's a big red flag.
Murphy's sign and Charcot's triad, definitely ones to remember for exams. So if you suspect cholecystitis based on all this, what investigations do you order?
Right. First off, you do the basic observations, vitals,
Yeah.
respiratory rate, heart rate, BP, temperature, oxygen sats, standard stuff.
Sure.
Then blood tests are key. A full blood count, FBC, might show raised white cells, leukocytosis suggesting infection.
Okay.
CRP, C-reactive protein, will likely be up, showing inflammation. Liver function tests, LFTs, are really important. You might see raised bilirubin if pile's backing up, raised ALT and AST maybe, and definitely look at ALP and GGT. Those often go up with bile duct problems.
Right, the liver enzymes.
And you absolutely need to check amylase and lipase to rule out pancreatitis because it's a key differential.
Okay, so bloods give a lot of clues. What about actually seeing the gallbladder imaging?
Imaging is essential. The go-to first test is an abdominal ultrasound, or USS.
Ultrasound first. Why?
It's really good at looking at the gallbladder. It can show if the wall is thickened, usually more than 3 millimeters is significant. It can show if the gallbladder is distended, stretched out. And crucially, it can spot gallstones. Sometimes it might also show fluid around the gallbladder, pericholecystic fluid, or even, in severe cases, air in the gallbladder wall, which is a bad sign.
Okay. What if the ultrasound isn't clear or you're worried about complications?
Well, then you might move on to other things. An abdominal CT scan is often used if you suspect complications like perforation or an abscess or perhaps sepsis.
Right.
There's also something called HIDO coloscintigraphy. It's a nuclear medicine scan, more specialized. It basically shows if the cystic duct is blocked by seeing if a tracer substance can get into the gallbladder. You might use it if the ultrasound was a bit equivocal. And just a point, if the ultrasound shows a thick gallbladder wall but no stones, you have to think about Acalculous cholecystitis. That can happen, especially in very unwell, perhaps intensive care patients.
Good point. So ultrasound first, then CT or HIDA if needed. Once the diagnosis is confirmed, how do we manage it?
Okay, management depends a bit on whether it's acute or chronic. For acute cholecystitis, it's usually a hospital admission job.
Right, needs hospital care.
Yeah. The initial steps are often supportive. Keep the patient nil by mouth NBM to rest the gallbladder. Give IV fluids because they're not drinking and might be dehydrated. Start 4V antibiotics need to cover the likely bugs like E. coli, Klebsiella, and Enterococcus. Local guidelines are key here.
Okay, fluids, antibiotics, rest the gut. What about the pain?
Pain relief is vital. You'd usually start with paracetamol and an NSAID, like ibuprofen, assuming no contraindications. If that's not enough, you might need stronger stuff like opioids, maybe morphine, and anti-sickness meds like cyclizine if they're feeling nauseous or vomiting.
So get the immediate situation under control. What's the long-term fix for acute cholecystitis?
The definitive treatment is usually surgery to remove the gallbladder, a laparoscopic cholecystectomy, or lap-chol, keyhole surgery.
When do they do that?
Ideally, if the patient is stable, you'd aim to do it within about a week of the symptoms starting. It's called an early lap-chol.
Okay, what if they can't have surgery straight away?
If surgery is delayed, maybe because the inflammation needs to settle more or the patient isn't fit right then, it's often scheduled for about 6 weeks after everything has calmed down. Doing it too late after the acute episode can sometimes make the surgery trickier.
Right. And what if someone is just too unwell for surgery altogether?
In that situation, particularly for very frail or sick patients, an alternative is a percutaneous cholecystostomy. That's where a drain is put through the skin directly into the gallbladder under imaging guidance to drain the infected bile. It doesn't remove the gallbladder, but it deals with the acute infection.
Okay, that makes sense. What about managing chronic cholecystitis?
For chronic cases, with those milder intermittent symptoms, it might be managed more conservatively initially. Things like dietary changes, especially avoiding fatty foods, which can trigger symptoms and pain relief when needed. But if symptoms are frequent or really bothersome, an elective planned lap-chol might still be recommended.
Got it. So overall, what's the outlook for someone who gets treated for cholecystitis, the prognosis?
Generally, it's pretty good if it's caught and treated appropriately, especially with surgery. The lap-chol usually sorts out the symptoms completely, and obviously the risk of it coming back is very low once the gallbladder is out.
That's reassuring.
But,
Right.
and it's an important but, if it's left untreated or if it's a particularly severe case, those complications we mentioned earlier can definitely happen and they can be serious.
Right. Which brings us back to complications. Can we just run through those potential problems again?
Sure. The big ones to worry about are gallbladder gangrene, where the tissue dies off, gallbladder perforation, where it bursts, abscess formation either inside or around the gallbladder, bile peritonitis, if bile leaks into the abdominal cavity, and sepsis, that overwhelming body-wide infection. Patients can also develop stones in the common bile duct as a related issue.
Nasty stuff.
Yeah. And some specific name complications include Merizzi syndrome. That's where a stone in the cystic duct actually squashes the main bile duct, causing jaundice. And gallbladder empyema, basically the gallbladder filling up with pus. That needs urgent drainage, either via surgery or that percutaneous drain if surgery isn't possible.
Okay, so definitely not something to ignore. That was a really thorough run through. To just crystallize it for revision, what are the absolute key takeaways?
Okay, Q points. Cholecystitis, inflammation of the gallbladder, usually caused by gallstones blocking the cystic duct. Classic symptoms. Severe RUQ pain, maybe radiating to shoulder. Fever, nausea, vomiting. Murphy's sign is important.
Right.
Ultrasound is your first-line investigation. Main treatment for acute is IV fluids, IV antibiotics, pain relief, and then usually a laparoscopic cholecystectomy, ideally early. And always be aware of those potential complications like gangrene, perforation, sepsis.
Perfect summary. Really helps seeing how that initial blockage cascades into inflammation, potential infection, and all the clinical features and risks. And thinking about those risk factors, the 4Fs idea helps frame who might be susceptible.
Exactly. Understanding the why makes remembering the what's much easier, doesn't it?
Right.
And yeah, knowing the risk factors helps with clinical suspicion.
Absolutely. Well, that wraps up our deep dive on cholecystitis. We really hope that's been useful and high yield for your MSRA revision.
Hope so too.
For loads more great revision resources, definitely check out PassonsSRA.com and also freemsra.com. Thanks for joining us today on the deep dive.
Thanks, everyone.